Question 1. The height of the jugular venous pulse is determined by A. Right atrial pressure, B. Right ventricle pressure, C. Left atrial pressure, D. Left ventricle pressure. Answer will be the option A. Let's see the explanation. Examination of the jugular veins provides an estimate of the right atrial pressure. Typically, the patient is examined at a 45-degree angle, and jugular venous pressure, JVP, is quantified in centimeters of water by estimating the height of the venous column of blood above the sternal angle in centimeters and then adding 5. In patients with mild right heart failure, JVP may be normal at rest, less than or equal to 8 centimeters of water, but increase with compression of the right upper quadrant. Hepatojugular reflux is elicited by applying firm continuous pressure over the liver for 15 to 30 seconds while observing the neck veins. Question 2. The SA node is situated at the junction of A. SVC and RA, B. SVC and LA, C. LA and LV, D. IVC and RA. Answer will be the option A. Let's see the explanation. The SA node is located at the junction of the crista terminalis in the upper wall of the right atrium and the opening of the superior vena cava. It comprises specialized atrial cells that depolarize at a rate influenced by the autonomic nervous system and by circulating catecholamines. Question 3. High output cardiac failure is caused by which of the following diseases? 1. Beriberi. 2. Severe anemia. 3. Thyrotoxicosis. Select the correct answer using the code given below. A. 1 and 2 only. B. 2 and 3 only. C. 1 and 3 only. D. 1, 2 and 3. Answer will be the option D. Let's see the explanation. High output failure, sometimes cardiac failure, can occur in patients without heart disease due to a large arteriovenous shunt, or where there is an excessively high cardiac output due to beriberi, severe anemia, or thyrotoxicosis. Question 4. Reverse splitting of second heart sound is most commonly seen in A. ASD, B. Severe MR, C. LBBB, D. Pulmonary hypertension. Answer will be the option C. Let's see the explanation. In the left bundle branch block, LBBB and RBBB, depolarization proceeds through a slow myocardial route in the affected ventricle rather than through the rapidly conducting Purkinje tissues that constitute the bundle branches. This causes delayed conduction into the LV or RV, broadens the QRS complex, more than equal to 0.12 second, and produces characteristic alterations in QRS morphology. Reverse splitting, paradoxical splitting, indicates pathology due to delay of aortic valve closing. Aortic stenosis, hypertrophic cardiomyopathy, left bundle branch block, LBBB, and a ventricular pacemaker could all cause a reverse splitting of the second heart sound. Question 5. Which of the following are major criteria under the Jones criteria for acute rheumatic fever? A. Chorea, B. Erythema marginatum, C. Subcutaneous nodules, D. Polyarthralgia. Select the correct answer using the code given below. A. 1, 2 and 3, B. 1, 2 and 4, C. 1, 3 and 4, D. 2, 3 and 4. Answer will be the option A. Let's see the explanation. Using the revised Jones criteria, the diagnosis is based on 2 or more major manifestations, or 1 major and 2 or more minor manifestations, along with evidence of preceding streptococcal infection. A presumptive diagnosis of acute rheumatic fever can be made without evidence of preceding streptococcal infection in cases of isolated chorea or pancreatitis, if other causes have been excluded. In cases of established rheumatic heart disease or prior rheumatic fever, acute rheumatic fever can be diagnosed based only on the presence of multiple minor criteria and evidence of preceding group of streptococcal pharyngitis. Major manifestations are carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. Minor manifestations are fever, arthralgia, raised erythrocyte sedimentation rate or C-reactive protein, and previous rheumatic fever. leukocytosis, first-degree atrioventricular block, plus supporting evidence of preceding streptococcal infection, recent scarlet fever, raised anti-streptolacin O or other streptococcal antibody titer, positive throat culture.